welcome everyone, and thank you for joining us tonight. This is an Australian Sickle Cell Advocacy education session. And for those that are joining us for the first time today, my name is Agnes. I'm the co-founder of Australian Sickle Cell Advocacy. And our primary goal for us is to advocate and educate and raise awareness about with people in the community about sickle cell disease, as well as those within outside the general community. So before I begin, I just want to acknowledge the traditional owners of the land on which we work, even if we're doing it virtually. I pay my respects to the elders, past, present, and emerging. So just a couple of housekeeping items we must address before we begin. Today's talks are regarded as an vocational information discussion only. The contents of these discussions do not apply to your personal condition. So if you've got any specific questions that you need to ask, direct them to your GP. We've got doctors on the panel, but they'll give you general answers only. If you don't have a GP or rheumatologist looking after your condition, please contact us and we'll be able to connect you with one. And if you have any questions for our panelists this evening, please add them to the Facebook page, as we do have a Q&A session at the end of the presentation. We endeavor to answer them all during the course of the evening. So we thought about this. We had a discussion with Isabel the other day, what we are going to do about National Blood Donors Week. So we thought we could do something like this, but also engage like Dr. Dali, who's from the Red Cross Lifeblood, and how important blood donations and blood transfusions are for the management of sickle cell disease. And that's why we are here today. So I would like to thank our distinguished panelists for giving up your time tonight. Dr. James Dali, we have Clinical Professor Joy Ho AM, she's in New South Wales. We have Alex, who's in Queensland. Mwewa, the caregiver, she's in South Australia. We have Patrick, a newest member, as I said, he's in New South Wales. We have Zachary also, who's in Queensland. And we have Jackie in Queensland too. We have Joseph, who's in New South. We have Natalie, who's in Victoria with me. So we'll have a presentation by Dr. James Dali, who's the Medical Director for Pathology and Services from the Australian Red Cross Lifeblood.
And I'm just going to talk a little bit about improving transfusion support. If I can here. So I thought initially I'd just quickly cover a few topics related to transfusion support of people with sickle cell disease and what Lifeblood is doing to improve this transfusion support. There's quite a lot of information in here and I'll go through it reasonably quickly, but you're welcome to stop me and ask questions or ask questions at the end. Now it won't go down. Okay, so I thought I'd first start with an introduction to blood groups and really just explain that it's more than just, it's more complicated than just the group A, B and O blood groups. So every person differs in their appearance and it's largely due to their genetic variation. And likewise, there's extraordinary variation in the way our red blood cells appear, at least to our immune systems. And that's due to genetic variation in the structure of the surfaces of the red cells. And that determines their blood groups. The A, B and O blood group is really just one of many blood groups that we all have on all of our red blood cells. And in fact, the ABO and the RHD, which is a positive and negative blood group, is just one of over 38 different blood group systems. And there's over 350 different blood group antigens that we all have. So the combinations of blood groups that somebody has or has not got on their red cells is called their phenotype. So this is a common phenotype or blood group. In fact, it's my blood group. So I'm blood group O. So I can receive red cells from only group O donors. So that's 46% of our donors. I also lack the big S antigen. So if I want to have a blood transfusion that's matched for that blood type, only 15% of donors will match. I'm also RHD or positive blood group, but I lack the little c and the big E blood group antigens. So if I want to match for those blood groups as well, only 17% of donors will match. So none of these is a rare blood group. It's pretty ordinary actually, but in combination, if I want to exactly match my blood transfusion just for these blood groups I've mentioned, it's 46% of 15% of 17%. So it means only 1 in 80 donors is going to be a match for all of those blood group antigens for me. So why do blood groups matter? Well, it's because our immune systems don't like blood groups that don't belong to us. Everyone has antibodies or an immune response against the A, B, and O blood groups that they lack. So we always have to match transfusions to the A, B, and O group or make them compatible to the recipient. But the antibodies to other blood group antigens, they generally only occur when someone has been transfused with blood that carries that blood group and they don't have the blood group. So their immune system recognizes this new blood group antigen as not belonging to them or being non-self, and it may form a response against that blood group or an antibody. And in future, if the same blood group is present on a future blood transfusion, the recipient's immune system can attack those transfused red cells and break them down. And you can see in this little cartoon here that the first time they're exposed to the red blood cell, they have these little antibodies attach. And then the next time they're exposed to the same blood group, their levels of antibodies increase quite significantly, and it can break down those red cells. So that can cause an acute transfusion reaction or can just limit the effectiveness of the transfusion because those red cells are broken down and removed. Because people with sickle cell disease are commonly transfused, they often form red cell antibodies. And in fact, around 30 to 50% of people with transfusion-dependent sickle cell disease will have red cell antibodies. The more transfusions someone gets, the more likely they are to develop red cell antibodies. But there are some people who don't respond to in this way, and they will never form red cell antibodies, regardless of how many transfusions they get. So mostly when we know a person has a red cell antibody, we can find blood that lacks that relevant blood group and is compatible for their transfusions. But sometimes if a person has antibodies to many different blood group antigens or blood groups, or if they have an antibody against a blood group that's very common amongst our donors, it becomes very hard to find a compatible transfusion for them. So what can we do about red cell antibodies? For most transfusions, we only match for ABO and the positive, negative, or RHD blood groups. But for some people who've had red cell antibodies, we need to match much more closely for other blood groups as well. For patients who get regular transfusion, like patients with sickle cell disease, it may be worth trying to match their blood more closely from the start of their transfusion career or history, just to try and avoid them developing these red cell antibodies. But depending on their blood type, this might not be, it might not even be possible to find regular, fully matched red cells. So what about rare blood types? So blood types are considered rare if less than 1 in 1,000 donors have that blood type. And it's usually the lack of a common blood group that makes a blood type rare. So a blood group that nearly everyone has, but someone doesn't have, is often the cause of a rare blood type. So people that lack very common blood groups can form an antibody response against that blood group when they have a transfusion. And from then on, it may mean that they can only ever be transfused with blood that is also from a rare blood donor that lacks the same common blood group, if that makes sense. And so this is an example. Some rare blood groups are more common in certain ethnic populations. And this is an example of earlier this year, we called out for Polynesian, Maori and Filipino donors because we were trying to find blood that lacked the KID A and KID B or JKA, JKB antigens. Now, this is a very rare blood type in most populations who almost all have either JKA or JKB or both on their red cells. But about 1% of Polynesian people lack both the JKA and the JKB blood groups. So it's still uncommon, but much more common in those populations than in our donor population. So we do have a few donors we've identified with this blood type, and we have some units frozen away for use if we need this particular rare blood group. We can also call on our International Blood Service friends for help if we need rare blood. And in this case, we requested some compatible red cells from the New Zealand Blood Service. With their Maori population, they have a larger group of known donors of this type. Last year, we also called for donors of Indian and Pakistani backgrounds as part of a global effort to try and find a rare blood that lacked the Indian B or INB blood group. And it was for a little girl over in Florida that was widely advertised. So this is a rare blood type that in almost all populations, except about 4% of Indian, Pakistani and Iranian people may be INB negative. So we called for these donors and we tested the donors for this INB blood group, which we don't routinely test for. And we did have a donor with this rare type, and we were able to send a unit across to help support this girl through her chemotherapy and stem cell transplant. And she's now in remission, which is a great news story. So in terms of sickle cell disease, it's more common in people of sub-Saharan African and Middle Eastern and Mediterranean backgrounds. And some rare blood groups are also more common in these populations as well. In particular, some of the variants of the rhesus blood groups, and also something called the Duffy null blood type, where both the Duffy A or FYA and the FYB antigens or blood groups are missing. So if a sickle cell patient has one of these rare blood types and develops an antibody against the common blood groups, it can become very challenging to find compatible blood for their transfusion support. So what is Lifeblood doing about this? Well, I'll quickly cover how we're trying to make it easier to find transfusion support for patients. Firstly, we're increasing the range of blood groups we test on our donors. You can't find a rare blood donor if you don't test for the rare blood groups. So we test all our donors, every donation actually, for ABO and the RHD, obviously. And since 2006, we've been testing all new donors for the more extended rhesus and KEL blood groups. Since February last year, we've started an automated testing of a broader spectrum of blood groups, including the FYA, FYB, JKA, JKB, M and S systems. And we're trying to test about 5% of donors per week. So 35,000 donors per year will be tested in this system. And last April, we commenced a new test with genotyping. So this is a very powerful test that in a single test can determine that whole range of or blood groups that I've got listed there on the screen. And we're planning, it's an expensive test, and so we can't do it on everyone, but we're aiming to test around 7,000 donors per year initially. So these measures mean it'll be easier for us to find red cells to match specific needs of our patients. So secondly, we're increasing the diversity of our donors, and we're running a series of projects to called the Increase in Representation of Australia Donors, or the INROADS project. The first part's aimed at identifying the ethnic background of our donors. So until now, we've really only asked the country of birth, and with obviously second, third, fourth generation people migrating to Australia and also overseas, the country of birth doesn't necessarily represent the ethnic background or the likelihood of a rare blood type. The second part is looking to improve the recruitment and retention of donors from different ethnic backgrounds. And we're aware that I guess some of our imagery and marketing may have been very much focused to our Caucasian donor base and not particularly sensitive to different cultures. So the third part is also looking at increasing the proportion of our donors for who we have performed this extended blood group typing on. So very quickly, I just wanted to cover this because we had discussions with Agnes about this previously. I just wanted to cover the eligibility of people with sickle cell disease and sickle cell trait for blood donation. So people with sickle cell disease can't be blood donors, and it's probably not in their interest to be. In Australia, people with sickle cell trait are also currently advised not to donate blood. Now, we don't test all blood donors for sickle cell trait, but a donor may tell us they have sickle cell trait, or we may discover a donor has sickle cell trait because their donation repeatedly clogs up one of the filters we use in our processing to remove white cells. And if we find this happen repeatedly in a donor, it does mean we have to discard the donation. And so if it happens more than a few times with the same donor, we think we don't want to keep throwing out these donations, and we ask the donor to get tested for sickle cell trait. And that's one of a few causes of this recurrent filter blocking. We also may discover a donor has sickle cell trait if we do that blood group genotyping test I mentioned, because it also includes the genetic change for sickle cell trait. And if we find that that positive, we will notify the donors about that finding. So while people who have sickle cell disease and sickle cell carriers can't be donors, certainly your extended family and your broader community are very much welcome and encouraged to become blood donors. So very quickly now, I just wanted to say this is National Blood Donor Week. And I'd like to make a special thanks to our very generous blood donors who help support everything we do. Around 500,000 Australians are active blood donors, and they've made 1.5 million donations last year. So a big thank you to them. And that's all. Also, thank you to Australian governments for supporting Lifeblood.
Thank you.
Thank you very much. Isabel, do you want to come in? Isabel, are you there?
Yeah, I'm here.
Stop sharing now.
Okay.
Sorry.
We can introduce our next panelist, Dr. Hall, Professor Hall, sorry.
Oh, you'd like me to do that?
Yeah.
Okay. So our next panelist is Professor Joy Ho from the University of Sydney, Acting Director of Haematology and Director of Research Institute of Haematology at the Royal Prince Alfred Hospital. Could everyone please welcome Professor Joy Ho?
Thank you, Professor Joy.
Welcome.
Welcome. So you're mute. So I know we had a discussion that you're not doing presentation, a PowerPoint presentation. So you can just, whatever you prepared, you're happy with that.
Perhaps just talk about what you actually do. Yeah.
So I might say that I have prepared a presentation for tomorrow. I actually wasn't aware that I was going to do one today, but in any case, I really want to thank James for a really clear and excellent presentation. And it ties in, the Sickle Cell Awareness Week ties in so well with the Donor Week, because blood transfusions is indeed one of the mainstays of treatment of sickle cell disease, as James clearly have indicated. And it's got to be said that with the use of blood transfusion is not only in acute crises, but there are many patients who, despite the use of hydroxyurea, for instance, still experience crises which are severe and life-threatening, such as chest crises and neurological syndromes. Now, whereas there are some data which indicate, for instance, that hydroxyurea does assist in preventing chest syndromes, in neurological syndromes, the data has been relatively recent, and even in more recent years, the data is better for children, but even for adults with neurological syndromes of brain crises, we often prefer to put patients on transfusion as a way of preventing recurrence, which can be life-threatening. And of course, the other point to make here is the differentiation between simple transfusion and exchange transfusion. Simple transfusion, of course, is just transfusing from a donor blood as we normally do, but exchange transfusion, as many of you will know, is that we remove the sickle cell together with, well, subsequently and then replace that with donor blood. And the exchange transfusion is done by a machine called an apheresis machine. And the advantage of that is that while you do a exchange transfusion, you would not increase the hematocrit or the thickness of the blood, because when we transfuse patients, we have to be very careful that we do not overly increase the thickness of the blood. We call it hematocrit, and that number, if you see in a full blood count, we do not want it to be over 0.3. So even in our regularly transfused patients who do not undergo regular exchanges, and there are differences in protocol and differences in usual practice amongst different hospitals, even patients who undergo simple transfusion, we often do a manual exchange. So we basically take some blood off before just using like a blood donation before we give the blood. Take some of the patient's own blood off before we give the blood to prevent the thickness from increasing, but because there are very clear and well-established data over many years that by increasing the thickness of the blood, particularly if it is above 0.3, will lead to an increased risk of sickling. And finally, I might just make a comment about blood grouping, with which James has already explained in with great clarity. Essentially, as you have heard, the donor pool in a country like Australia is still predominantly Caucasian. And therefore, when we have a population of a particular illness, such as sickle cell disease, who are of a different ethnic group, it is often in the old days, before our awareness of that ethnic difference and the implications on blood groups and formation of antibodies, that antibody formation was common, and that was a very regrettable thing, because this alloimmunization, meaning people forming antibodies, can in fact be a very, very difficult and complicated problem. So this ethnic difference would make us want to encourage everyone online now and from various communities who have sickle cell disease to become blood donors and encourage your own communities, so that that difference of ethnic difference is reduced as much as possible. That's about all I'd like to say, and I'd be happy to take any questions. In reference to, I think it was Isabella who introduced me, what I do is that I'm a hematologist at a hospital in Sydney called Royal Prince Alfred. I'm currently the head there, but I have been the head of hemoglobinopathy unit for many years. So I've looked after sickle cell patients, sickle cell disease patients and thalassemia patients for 25 years. So it's a great enthusiasm of mine, and it's wonderful to see the developments in not only the disease, but also in patient advocacy that has happened in recent years.
Thank you so much. So we have Dr. Ben Saxton and Dr. Juan who's joined us. I think maybe you can go in and just, because we didn't put on the spreadsheet because we are not sure what sort of topics you are going to present. So maybe you can just say something as well before we go into the questions from different participants. You can go ahead, Dr. Saxton.
Okay, yeah, sorry about that. Ben Saxton, I'm a pediatric hematologist in Adelaide, and I also have the privilege of working at Lifeblood. So James and Kobe are my colleagues there. And so I'm involved in the care of children with sickle cell disease who have very similar clinical problems to adults with sickle cell disease. We have a number of patients on hydroxyurea, and our number of patients is increasing in Adelaide, along with migration patterns towards South Australia from some of the African countries. We have a number of patients on regular transfusion programs, and those patients have, we give some chelation therapy as well to try to remove some of the iron, and annually we recommend an MRI of the liver and heart to track iron overload. So those are some of the aspects of the change in South Australia and some of the clinical aspects of what we're doing here in Adelaide.
Oh, so I'll continue. Yep, I'm Kobe van Willig. I work at Lifeblood in Melbourne at the moment, and Heimwehr. It's probably due to the girls that I started all of this. So I've been involved in treating sickle cell disease patients at Women's and Children's Hospital in Adelaide, where I did my training. And I had the privilege to be involved in treating the sickle cell patients. This sparked the interest in blood transfusion, and now that is what I do. I try to ascertain that the blood's available for the sickle cell patients. We do our utmost at all stages to make sure that the patients receive the blood that the clinicians request, and that will be the best or most suitable that we can provide to prevent antibodies being formed by the patient who has sickle cell disease. We often put lots and lots and lots of time and days of work into it to make sure that your children or you receive the best blood that we can supply through Lifeblood. So that is what we do. I work in Melbourne predominantly and cover Western Australia as well. Some days of the week, and in both these states we have quite a few sickle cell patients, and as Ben mentioned, we see a steady increase in the number of sickle cell patients over the years, and I think everybody working in a hospital will know that there's a steady increase, as Ben mentioned, by our migration patterns, and as both James and Joy alluded to, if we can get you and your family, especially those that doesn't even have sickle cell trait, to donate, we would probably increase the amount of blood that's available for other patients that may have a similar antigen profile on their red cells, or and we can avoid patients making antibodies and making it extremely difficult to transfuse once they have antibodies.
All right, well, thank you for that. I think at this point we'll get some questions before we dive into the different warriors that we have on the panel. So I don't have any questions in the Q&A, so just go by whoever raises their hands. If you want to have any questions, you can start asking questions as we go.
I guess I've got one question, and that would be within the treatment of people that do have sickle cell disease. Do you have a use of exchange transfusion more than you would just have a normal transfusion with people with sickle cell with the patients within your care? Do you mainly do exchange transfusions or just a normal blood transfusion to lower down the sickle cell that's being produced by these patients?
So I might answer first before Ben and others. So essentially we have currently about 4 out of many other patients, so 4 patients on regular exchanges.
Okay.
They have machine exchange transfusions,
okay,
manual exchanges, for specific reasons. Previous multiple crises, including neurological crises, chest crises, even there are 2, in fact, who have very severe recurrent bony crises, which we could not control otherwise. I actually did forget I have 2 other patients who are on regular exchanges, and this might actually bring up the issue of differences in policy. So I take a lot of patients as they grow up from Westmead Children's Hospital, and at one stage their policy was that they were putting their majority of patients onto regular apheresis exchange. I'm an adult physician, so I wasn't part of that decision, but I discussed with my colleagues, my own executive administration. Actually, it's not the executive, but the general administration of our hospital, as well as my colleagues in the US, including my previous supervisor during my study days in the UK, who is now at the NIH, and I was comfortable in saying that it does not necessarily have to be the standard of care to perform apheresis exchange for all patients. And given the restriction of our resources, I did have to indicate that I cannot take all children into my hospital and administer regular exchanges. It is not possible. So there is a difference in opinion and difference in policy, even in the US. So for instance, I think in Oakland Children's Hospital, many patients are regularly exchange transfused by the apheresis machine, and yet at the NIH, that is, they use the same protocols and selection criteria as we do.
So basically, is there a difference in treatment though? So if you're having an apheresis, do you think that sickening crises would be less as opposed to just having a normal transfusion? So you're you believe
So
that within your experience, it actually really doesn't make a difference?
Look, in my opinion, when we manage our regular exchanges, regular transfusions,
Yes.
which could be often with manual exchanges, so just
Yes.
taking some blood off, with appropriate treatments, I think we manage them very well. They don't have marked increase in crises as compared with those who have regular machine exchange transfusions. But I put it to you, Isabella, that those patients whom we have put onto regular exchange transfusions by the apheresis machines, they actually have more severe disease. That's the reason why they got put on.
Okay.
Mm.
Thank you.
Thank you.
I do have a question from the Facebook page from Cremelda Wilson, and they ask, at what stage do patients need blood transfusions? So not all sickle cell patients have regular transfusions, I suppose. Anyone want to take that one?
Ben?
Joy, do you want me to
Yes,
start?
Ben, why don't you do that?
That'd be great, Ben.
Thank
Go
you.
ahead.
So transfusions often start in childhood.
Mm.
So there's pretty good guidelines now, particularly the US guidelines about recommending when to start transfusions in children. So the advantage of transfusions is you can get the total amount of hemoglobin S low, which reduces the risk of having some sort of crisis. The disadvantage of transfusions is that your body builds up iron and you need some sort of mechanism to remove that iron out of your body, otherwise it becomes toxic. There was, for quite a long time, people thought in children, if you did an exchange, so you remove some of the red cells out and put in non-sickle red cells, then you may reduce the risk of iron buildup because you not just keep putting more and more in. And that was the main driver of, like, Sydney Children's, for example, wanting to put everybody who needed transfusions onto exchange transfusions. Now, not all pediatric hospitals do that. We use exchange transfusions in Adelaide very sparingly. It's really just for people with the most severe disease, like very severe chest crises and that sort of thing. Our preference would be to try to get that hemoglobin S level changed using medications like hydroxyurea, also known as hydroxycarbamide, and reduce the risk of sickle complications with medications rather than with transfusions. The other advantage is the less transfusions you have, the less risk of developing antibodies and the less risk of not being able to find blood, as James was talking about in his presentation. So I haven't given a straight answer, but somebody who has a young child who has an abnormal transcranial ultrasound that says there's a risk of having stroke, we would recommend starting transfusions and then hydroxyurea later. Someone who's had a stroke, to prevent other strokes, we would definitely recommend regular transfusions. Somebody who's not having many problems at all, or maybe just one bony crisis, but at a slightly older age, we wouldn't necessarily recommend starting transfusions for that person, because we have to balance the benefits versus the risk with it. So they're quite lengthy discussions about when to start.
Yes.
And then once the patient's getting to 18, then they go over to someone like Joy who goes, what have they done? And, you know, so just because you start transfusions doesn't mean that you have to stay on them. But if it's for risk of stroke or because there's been strokes before, this often means a lifelong or near lifelong transfusion program.
I've got a question, I think, following on to the same. If somebody has iron buildup, for example, they've got iron overload, would red cell exchange be a better option for treatment than normal transfusions? Whilst you're also dealing on the iron overload, you're taking iron chelation, but if you've got so much buildup of the iron, would red cell exchange help to reduce that iron overload?
You know, that's precisely why in California in particular, as Joy mentioned, that's the key reason for having, oh, sorry, my computer's ringing. That's the key reason for having an exchange program for children, to try to reduce that risk of iron overload. The data is not completely convincing that it actually does what it's intended to do, which is why it's not standard of care absolutely everywhere.
Okay.
I will also just mention in agreement with Ben, I really liked his joke that, you know, yes, they then come to us, and the difficulty and a lot of discussion has to talk about resources. So the pediatricians look after the children till 16 and a half. We have to look after them for the rest of their lives, right? So they hopefully will live to old age, and we are heading there. You know, a lot of our patients are getting old. So it is a very difficult issue. I might say that, agree with Ben again, that a lot of the pediatric units who do that, who do exchanges for every patient who we would put on simple exchanges, do precisely what for that reason of reducing iron. But as you know, there are in fact good iron chelators now, which if used can control their iron.
Anybody else with the question, or can I ask another question? I may ask another question if there's no one
We've got a couple more on Facebook. Yeah, we've got a couple more on Facebook.
Okay, ask that question then, Isabel.
Okay. So Harrison Darko has asked two questions. So we'll start off with the first one. What causes high platelet levels in his son, which have been high? He's taking aspirin and he's also on a hydroxyurea. What do you think?
So I'll give my opinion, and others will too. So patients, I don't know how old Harrison's son is, but patients with sickle cell disease can have recurrent sickling of the spleen, and we use the term hyposplenic in the sense that even though their spleen was not removed, say by surgery, because of recurrent sickling, the spleen actually has multiple infarcts and the function goes down. So the most important effect of that is that people are susceptible to infection, and that's why patients have to be vaccinated, and children often are put on penicillin, for instance. But we have noticed, therefore, that patients who, because the spleen normally gets rid of various blood cells, that the effect of that could be that their platelets can go up. Platelets can also go up because of reactivity, whether it be due to infection or other reactive causes, meaning other illnesses. Ben, can you think of any other reasons? Probably hyposplenism is one of the main issues, I think.
Yeah, I agree. Hyposplenism and reactive changes with infections.
Okay.
Other more sinister causes are really uncommon in young patients.
His son is 3, you just mentioned then.
It sounds like it's a spleen-related thing.
Okay. And the other question that he had was, is there any gene therapy for the treatment of sickle cell here in Australia?
So no, there's no gene therapy for sickle cells here in Australia. We have done gene therapy for thalassemia, but not
Yes.
sickle cell disease.
Mm.
We have tried to attract them, may I say, and we've done some negotiations and so forth, but we haven't yet been successful.
Okay. Okay, that's it from Facebook.
Okay, I think I may ask a question, I think directed to Dr. Gali, and we've had this discussion before. I'm only asking this question because I was quite unaware today when we had the interview with SBS. So you touched on the point of people with sickle cell trait not being able to donate blood. Now, I've also talked about having the red cell exchange treatment using the similar apheresis machine. Would you just explain to us the difference, what happens when somebody's having for example, if you're doing plasma, for example, plasma donation, because you're using a similar machine, and when you're doing the red cell exchange treatment, you're using the similar machine. What's the difference between somebody who's living with sickle cell disease and somebody who has the sickle cell trait? You've done an explanation for me before, but I could not explain it very well this afternoon. I just want you to explain again so that people watching this can understand.
Yes, so I see your point that it seems a bit counterintuitive that we say people with sickle cell trait can't donate via apheresis because of the risk of it causing sickling, yet we use apheresis machines to do red cell exchange to treat sickle crises or prevent sickle crises in people with sickle cell disease. But I guess to some extent the risk of sickling during an apheresis procedure on someone with sickle cell trait is relatively theoretical and maybe is a very low risk. We know a lot of countries don't screen for sickle cell trait in their plasma donors who donate. In the States you can donate plasma twice a week by apheresis, and so there would be considerable numbers of people with sickle cell trait who are donating by plasmapheresis, and it's not a clear and high risk of causing problems. I guess one of the reasons we so that is a small risk, and that risk that Lifeblood is looking into that risk again and monitoring progress and evidence published about that risk. And as I mentioned to you in previous discussions, I guess the practice around the world about eligibility for plasma donation from people with sickle cell trait is different in different countries. At the moment, Lifeblood has that exclusion in place, but we'll monitor that and hopefully review it. There is a difference, I guess, between a plasma donation and a red cell exchange, where you're removing the red cells and replacing them with red cells without hemoglobin S in them. But I think it doesn't sit well that the difference in that policy, and that risk is being reviewed. One of the main reasons I guess we don't like to encourage whole blood donations from people with sickle cell trait is that fact that when we get the donation into the processing centre and try and process it into different components and run it through a white cell filter, it often just blocks the filter, and it means the whole donation gets discarded. So it's a waste of time for the donor, it's a waste of their blood, and it's a waste of resources, I guess, for everyone if that's happening repeatedly. And it often does with people with sickle cell trait, that white cell filter gets blocked. And so we tend not to encourage whole blood donations either from people with sickle cell trait, just to avoid that wastage.
So would you say the onus is on us if we know our sickle cell status when we're about to donate plasma to say that I've got the trait?
Yes, that's right. So we don't, as I said, we don't test all donors for sickle cell trait, but we do. There is a question in the donor eligibility that says, have you ever had a blood disease? And I understand that some people may not consider sickle cell trait a blood disease. So maybe the wording or terminology of that question doesn't bring out that answer. But certainly if you know you have sickle cell trait, we would anticipate donors would mention that at that donor question. And we could have that discussion then. But as Kobe mentioned, some family members of some of our patients who are very difficult to find compatible blood for, some of their family members don't have sickle cell disease or sickle cell trait, but have the same blood group. So they're perfect donors for their red cells. And actually they have very rare blood groups. And so we do call on people's extended family, if they don't have sickle cell trait, to be donors if possible.
Thank you. We have a question in the chat box for Professor Joy Ho. Have you come across sickle cell patients with hereditary persistence of fetal hemoglobin in your practice?
Actually, not in my current practice, but when I worked in the UK, because there was a research interest in HPFH, or hereditary persistence of fetal hemoglobin, we did see them. And they would tend to have a milder phenotype, a milder manifestation of their sickle disease.
Okay. All right, I think at this point, Isabel, do you reckon we bring in our other warriors to just introduce themselves and how they live with sickle cell disease?
Yes, I think so. Otherwise, we're going to run out of time.
Yeah, we actually run out of time.
All right. So would you like to start that off, or do you want me to do that?
Go ahead.
Okay. So in the event of acknowledging National Blood Donors Week, we take a look through the eyes and minds of the recipients of donors' blood. So it's just going to be a roundtable discussion. I'm just going to ask questions to our sickle cell warriors about what it's like to receive blood donation. I think that's really important to get that side of thing. We have with us today, or this evening, we have got Alexis, Zachary, Jackie, and we also have Joseph. I don't see Costa in there.
Costa is not here.
Yeah, Costa. I know Costa is listening though. I know he's watching through our live through our Facebook. So I kind of just devised some questions, and hopefully I could get your feedback on what it's like to be a recipient of a blood donation, because our blood donors are our superheroes out there, and they're the ones that keep us alive, basically. And I think it's nice to acknowledge. It's nice for them to know that what they're doing is super important.
Yeah, exactly.
Yeah, so thank you to Lex, Zach, Costas, and Jackie and Joseph. Can you guys introduce yourself? We'll start off with Jackie, perhaps first. Would you like to tell us a bit about yourself? Let us know when and where you were born, your cultural background, and when you were first diagnosed with sickle cell.
You're mute. You're mute, Jackie.
Jackie,
you're mute.
We can't hear you.
We can't hear you. We can't hear you.
Agnes, can you unmute her?
I'll see if
Do
I
you have the
can.
power to unmute her?
Oh, I can actually. No.
There we go.
No. Did I?
I don't
Oh,
know.
yeah.
Here we are. Can you hear me?
Okay,
Yeah,
now we
now, yeah.
can. Sorry, I should have unmuted from the beginning. You have to
Okay.
start again. You have to start
Okay.
again.
Yeah.
No problem. Well, good evening, everyone. I'm very happy to be joining the group. And as you know, my name is Jackie Moore. I was born in 1957. So as Dr. Joe said, yes, we are getting older. 1957, and I was born in South Africa. So yeah, yes. Is that all you wanted to know right now?
When were you diagnosed with
When
sickle
were you
cell?
diagnosed?
Yeah. Were
I was
you 2 years old, 3
diagnosed-
years old? How old were you?
15 months. I was
Wow.
15 months, yeah. So that was quite early. My parents realized that something was wrong because I was, crying and in a lot of pain, it seemed.
Yes.
Yeah, and so, I had the typical swelling of the hands and the feet, a lot of bruising, and of course the yellowing of the skin and the eyes.
Yes.
And that's what led them to take me to the hospital. And the doctor then, initially they thought it was leukemia, but then further on they realized, well, with a few more tests, they realized that it was the sickle cell. So, and I'm HBSS, so I inherited from both parents.
Okay.
Yeah.
Joseph, are you still with us? There you are, up the top.
Yes, Joseph's still here. Yeah.
Yes, thank you all for this opportunity. My name is Joseph, and I was born in Nigeria. And I was born in 1990, so I'm 29 years old now. I was first diagnosed around 2 to 3 years old, I think, because the story my parents tell me is when I was born, they noticed that I was always crying, and like they didn't really know what was going on. And when I was around 2, 3, they took me to the hospital, and that was when I was diagnosed of sickle cell disease.
Hey, thank you.
Thank you.
Alexis, would you like
Alexis.
to share your story?
Hi everyone, I'm Alexis. I'm from Queensland. I was born in Victoria. Isabella is my mum. Zach is my brother. I was diagnosed at the age of 3. I was unwell all the time. Mum and dad couldn't figure out why. They took me to the doctor for testing. They also thought I had leukemia to begin with. And then after further testing, I was diagnosed with sickle cell beta thalassemia. And then soon after, my siblings were tested and my parents were tested also. My mum's a carrier of sickle cell and my dad is a carrier of thalassemia. Is that everything?
Yes.
Good job there, Lex.
Zachary.
Zach, do you want to share your story? You need to unmute yourself.
I will help.
Oh, good. There you go. Unmute. Unmute. There
Sorry,
we go.
I got it. I got it. Yeah.
Okay, good job.
Yeah.
I'll keep it short. Basically, like Lexis told the story because she was diagnosed. She's older, so she was diagnosed first, and then I got diagnosed later. But I'm like a year and a half younger, kind of.
Okay.
Yeah.
We have some caregivers on the panel as well. At this point, Mwewa, do you want to introduce yourself? Only if you guys are comfortable. Oh yeah.
Sure. Yeah. Thank you. Thank you. Yes. Maybe before we even get to that, just wanted to thank you all for the mighty work that you're doing. It's definitely making a difference in our lives. It's making a difference in our children and our community. So thank you. Thank you very much.
Yes. Yes.
I'm a mother. I'm a mother of 2 daughters. I have 2 beautiful young women who have sickle cell disease. I was fortunate. I didn't recognize Dr. Kobe. She was one of the hematologists looking after us at the Women's and Children's Hospital in Adelaide. So my girls go in there. They're on regular transfusions, both of them. Yeah, so we're just on this journey together to try and learn and grow and see how we can help each other.
Thank you. We also have another caregiver in Northern Territory. Ade, do you want to introduce yourself quickly? You're mute.
Unmute that person. There you go.
There you go.
Oh, it's back on mute.
Go back
Okay,
on. Okay.
my name is Ade from Northern Territory. I have a daughter who is sickle cell, and she's the only kid in Northern Territory with sickle cell.
No.
So that made it a bit difficult for my family to share with others. So, and sometimes we have to travel to South Australia for some treatments. But what I can say is that at 7 months, she got diagnosed, and she's been on hydroxyurea since then. And
Wow.
glory to God, there has never been any pain, no admission so far. So we've been managing her in the house. So that's, yeah.
Okay. Thank you very much. Isabel, what's next on this?
So the next question I have for our patients out there, and even the mums and dads that are out there, do you recall when or how old you were when you had your first blood transfusion, and what did it feel like receiving it for the first time? Were you worried? Were you scared? Were you happy? Do you recall how you felt after the transfusion? I know that you probably would have been very young, and it might have been a long time ago, so it might be a bit hard to recall. But maybe you have a really strong memory of what that was all about for you. Shall we start with Jackie? You can't hear Jackie, you're muted again. Someone unmute Jackie.
Unmute. Okay.
Oh, there you go.
Can you hear
Good
me
job.
now?
Yes, thank you, Jackie.
Don't know why I keep going to mute.
No, I did. There was a noise, so I had to mute everyone. There was a noise coming out. Sorry.
Okay. My first transfusion, well, my memory only goes back till when I was 5 years old. I don't remember much before that,
Yes.
but I do remember being transfused from 5 years onwards.
Okay.
So yeah, I have had numerous transfusions in my childhood, and of course, as we'll chat, I suppose, now more recently later on in life. But as a child, was I scared? Yes, I was scared. When you're little and you see those needles coming at you, it's a scary thing. And
Absolutely.
I do remember being quite scared and crying quite a lot every time I knew I was going to have a transfusion. But I also had a wonderful nurse who taught me how to be a very brave little girl. And I learned to cope with the regular transfusions. I don't recall how I felt afterwards, but I think I must have been better after the transfusions, because the doctors always seemed happy with the result afterwards, that they always used to look at my fingers and say I'm not so pale anymore.
Yeah.
So I think obviously they were getting the outcome that they wanted from the transfusions.
Okay.
Yeah.
Okay, thank you.
Okay. Joseph, are you there?
Yes. From memory, like I can't really remember, but I had a guess that I was going to be asked this question, so I had to ask my mom today. She said,
"Good job."
And she said the first time was when I was 8 years old, but I can't even remember what happened. Yeah, but from recent times, so that was 2017. I had blood transfusion here in Sydney. I can remember being scared, worried, because I didn't really know how it was going to affect my body.
Okay.
So, because I actually have a doctor, an uncle in Melbourne. So I had to call him, like, is this okay? Do you think that I should do it or not? Yeah. So yeah, I was really scared, and so it was quite a scary experience for me. But yeah, I'm glad that the blood was actually there to save my life.
Absolutely, absolutely. Lex, would you like to share your story?
All I remember is I had my first blood transfusion on my 5th birthday, And I remember a nurse coming in with a cupcake for my birthday. And I always remember going in for my transfusions when I was a little kid, and me and Zach would just run down the hall screaming because we didn't want needles. It was very traumatizing.
Yeah, very familiar with my daughter as well.
Yeah. I would still do it now if I could.
Zachary?
Zach,
I
would you like
don't.
to add that?
I don't really remember much. Like, so I don't remember us running down screaming, but that story does sound familiar. But yeah, I think I've always had like a positive sort of attitude towards going to hospital, as well as like as a kid compared to the adults hospital. Like, they try and make the experience very positive and very happy. There's lots of fun things to do. So the main thing I remember from being that young was like that it was a fun experience, even though it's not a good thing. Like, you know, getting needles is not fun, but like everything around you is made to be fun. So I don't really remember much besides that. And I used to always look at the needle when they would put the needle in, until I had a really bad experience and they had to try me like 7 times. And then from that point onwards, I stopped looking at the cannula when they would cannulate me. And from then on, I just don't look.
Okay.
Hey, thanks, guys.
Thank you. I'll just quickly go into our next segment, Isabel, mindful
Sure.
time.
Yeah,
so the
absolutely.
next question, so for the next question, quickly. So as adults now, when you are waiting for blood transfusions to begin, so for you guys who've just shared your story, do you ever wonder who the blood donor may be, and what the donor may be doing when they're receiving your blood transfusion? Whether they like the same things you like, or have a family? Do you ever ponder at what made them decide to donate blood in the first place? So this is directed at the people that donate the blood. Do you ever think about that person who actually gives you the blood? What made them decide? What they were doing? Do they have a family? So maybe we'll start again. This time we can start with Zachary or Jackie. Yeah, we can start with Jackie.
Okay. Well, yes, I do wonder about the donors, you know, just curiosity. Is it a male? Is it a female? Don't really wonder about what they're doing, but I'm curious to know, it would be nice to know, are they sports women or sportsmen or health fanatics, or what is their motivation to donating blood? Have they had an experience that they understand the importance of donating blood? So that is what I wonder about when I receive blood, you know, about the people who actually do donate. Yeah.
Okay. Thank you. Can we go to Zachary?
Yeah.
Same question. Thank you.
I'd probably more so not necessarily think of like the specifics of who they are, what they are, and what they do and all that, but yeah, more so what led them to get to the point where they felt motivated to go and donate blood. Like, you, as an adult, you meet a lot of people, and you know, the good and the bad, and it feels very nice to know that there are those few that do go and donate, and the good in them, sort of thing, is what I'm kind of interested in and think about.
Okay. Thank you. Joseph?
Yes, so as for me, when I usually take blood transfusion, so what I actually think it's just like what Zachary said, like what led them to want to donate their blood. And the second thing that I always think about is how grateful I am that there was actually a blood there for me to use. Yeah, so I think those are the two major things I always think about when I'm having blood transfusion.
Thank you. Alexis?
Same as everyone else, I really think about why do they donate? What has motivated them? Do they know someone that has needed it in the past? Is there someone close to them that needs it as well? Have they needed it in the past as well? And same as Joseph, I'm also very grateful that we do have this blood when we rock up to the hospital for our battery recharge, as I like to call it. because I have had the experience where I've had to wait over 24 hours for my blood to be matched because of the antibodies that my body has now. Yeah.
And from a caregiver's point of view, Mwewa, do you want to share anything? Thank you.
Yes, I was actually, as Dr. Daly was talking about persons with sickle cell trait not being able to donate blood. A part of me sometimes feels guilty that I'm not able to. And I've always been wondering and thinking, I wish I could just roll up my sleeves and, as they're taking blood out of me, they could give it to my daughters as they're having their transfusion at the same time. So yeah, there are those parts of me. I think, if I be honest, I feel a bit conflicted in a way that somebody else is having to do that and I'm not able to do that as their mother. So that's a part of it. But I think the bigger picture, yeah, is just that sense of gratitude, particularly when you hear stories of places where people are not able to get blood transfusion because it's not safe.
Yeah.
We don't have the protocols in place for that safety. So yeah, you kind of get out of there going, and we call it as well, we call it refueling. So it's a thing. We're refueling in 4 weeks' time. So
yeah.
So that's something that we kind of go and just make sure that it's a happy day, because
Yeah.
it can be quite draining emotionally as well.
Thank you. At this point, quickly, because I promoted everybody to be a panelist, we've seen names. Welcome. If anybody wants to share something, if you're comfortable, do you want just to share for a minute or so before we go into the next session? Go Chila S, Betty, Tina, Daniel, and Topsy. Can you hear us, guys?
We've got a couple of questions in the chat as well, Agnes.
Yes, do you want to read that?
These ones are directed to the doctors. So the question was asked, can the doctors talk about what they do if certain sickle cell patients take blood transfusions because of their religious, or can't take blood transfusions because of their religious beliefs, for example, Jehovah's Witnesses? Yeah, that's basically the question.
Kobe, you want to? I'll answer first. So, I mean, clearly blood transfusions is not the only treatment for sickle cell disease.
Yes.
Hydroxyurea should really be used much more commonly. And I would put you, even though this is a panel on blood transfusion, that people do have to remember the role of hydroxyurea. And I would answer that question by saying that obviously we respect religious beliefs of all patients, and sometimes we deal with Jehovah's Witnesses. I don't have any Jehovah's Witness patients with sickle cell disease, but with malignancies I do. And they often have counselors and so forth. And we go through all the various, make sure that that is indeed the patient's decision, but then try to use alternative means, hydroxyurea. Clearly, patients who refuse transfusions may not be considered a transplant candidate, but of course there are other drugs that are coming through, two of which have already been approved by the FDA. We don't know when they will come to Australia, but they are kind of things on the horizon.
Thank you, Dr. Professor Joy.
Is Dr. Maybe Dr. Saxon is not here?
No, I'm here.
Okay. Yeah. Do you want to add something to that?
I guess I completely agree with everything that Joyce just said. It's all about our respective beliefs and working with the families around their belief structures. The only difference is in a minor, so somebody under the age of 16, it does vary, age of consent varies a little bit between states, but let's say 16 as a rule of thumb. Somebody under that age can actually come under the influence of the state. So if a transfusion is strongly recommended by two medical practitioners, even if it's against the will of their parents, the state can say that the transfusion can go ahead. So there's a bit of a legal, ethical, like minefield attached to this question as well. But we try our best to avoid that path because having respectful conversations often avoids needing to go down that path, in fact. But really, the most important thing to remember is that transfusions is not the only option for treatment in this condition.
Thank you. Dr. Kobe, did you want to say something quick? You're mute.
No, I agree with Ben and with Joy. I think having the discussion and getting to a mutual agreement is what it's all about. And there are alternatives to transfusion for sickle cell disease, as Joy mentioned.
Thank you. Isabel, is there anything else so that we finish at least in the next 10 minutes?
Look, I'd like to say thanks to everyone for joining us tonight and creating awareness for blood donations within itself. And it's good to listen to different people's perspectives on that. So that's just been, just for me, it's been fantastic. As a parent of those 2 kids that are on there as well, it's been an interesting ride, I can tell you, in the past 25 years, educating people about sickle cell, especially in the medical community, because it was pretty rare back then. Now with the actual migration that's happening at the moment, it's a bit more out there. But when my kids were diagnosed back in the early 90s, it was an education, not just for us, but also educating medical communities that really had little to no knowledge about what sickle cell was at that time, or they had very old information. So thanks to everyone here tonight. That's been great. And thanks to all the sickle cell warriors out there that shared their stories tonight. It is a personal journey, and it's really nice to hear everyone's story. And it's interesting that just listening to all of you, and it doesn't matter how old you are, that your journey has been quite similar in most aspects. So that's also been good to listen to. Yeah. Are there any questions from anyone else, perhaps to the sickle cell warriors, that they might have?
No, I think at this point, quickly, because I'm very mindful of time, but also, just want to say thank you to everyone at this hour. We are live, and this Thursday we're having this discussion. But just a big thank you to everyone for coming and sharing your story. But I just wanted to quickly touch on what Mwewa said. That guilty of when we had our child, because for us, we are here today because our daughter was diagnosed 11 years ago. Now she had a bone marrow transplant, and she's had blood transfusions, platelets, and all those plasma. So there was that part, guilt, and I did donate plasma for 10 times. I did donate plasma because I just wanted to give back. So our family started donating. Then we realized that we're actually putting ourselves at risk, and that's how we stopped donating. So I'm still a strong advocate for people who can donate blood, and that's why we did this today. We've got a very big day tomorrow for World Sickle Cell Day, but we thought, the blood donor week can't just pass without us doing something. So thank you for everyone. So maybe quickly we can just go 2 seconds for the recipients for blood, and just thanking all the donors out there in Australia.
Yes, could I say something just
Absolutely.
to end?
Yes, please.
Yeah, I just want to say, and as the other 2 have said before, I'm extremely grateful to those who donate blood. When I'm having my transfusion and that bag of blood is hanging there and it's dripping into me, I'm extremely grateful and thankful to those people who do donate blood. So please keep on giving. It really is the gift of life. Thank you very much.
Definitely, yeah. Alexis, Zachary, then Joseph, then Mwewa, and anybody else wants to thank you, the blood donors at the end.
as Jackie said, blood is the gift of life. It gives all of us patients life, and it extends our lives to be with our families, and lucky enough to have our own families too.
Thank you. Zachary, 5
Yeah,
seconds.
I'm also very appreciative of everything everyone gives. When I get my apheresis and there's 6 bags up there, I know there's 6 people giving their blood each time I'm going. So I appreciate it very much.
Thank you. Joseph, you're mute. You are
Yes, I want to say
mute. Okay.
thank you, and I'm grateful for the blood and because it saved lives. Thank you.
Thank you. Mwewa, as a caregiver, and Ade.
Yeah, on behalf of my daughters, just want to say thank you for all the work you do as the doctors behind the scenes and the screening and all that education you do. So from our hearts, we say thank you.
Okay. Ade.
Okay, as a medical scientist, I know what it means to donate blood. So I want to say thanks to everyone out there who is donating blood to us to get something to use to keep life. So thank you to everyone.
Thank you. Alex Wako, would you just say one word before we go? Thank you for joining us. You're mute.
Thank you so much, doctors and the facilitators of this particular forum. We are grateful. I'm here with my wife, and we have a five years boy who is sickle cell positive, and is doing very well. He's taking hydroxyurea and some other things. But transfusion, he did once when he was 1.5 years, but right now has stabilized. Otherwise, I say thank you, and also be inviting us for these particular forums, because we can achieve more. Thank you.
Thank you. Where are you joining us from?
I'm joining you from Kenya, Nairobi, Kenya.
Oh,
Awesome.
interesting. Thank
Awesome.
you.
Welcome, Alex.
Fantastic.
Yeah.
Yeah, that's awesome. Welcome, Alex. Yeah.
Yeah. Well, thank you so much. At this point, if you've got any questions, we'll be able to send them through to the panelists. So to Dr. Dali in Brisbane again. Sorry, I said Adelaide at the beginning. I haven't told Moira that you're in Adelaide. I don't know what I was thinking. So he's in Brisbane. Professor Joy Ho, AM, I'm again with you tomorrow night. So I've got another 2 hours tonight. Dr. Ben Saxton and Dr. Colby, thank you so much for joining us. We appreciate. We just thought we all our lives to the people that are out there donating blood for each and every patient who's not only sickle cell patients, cancer patients, and those people in accidents and all. So we thought we just did something that we could to recognize Blood Donor Week. So thank you so much for joining us. All right.
Thank you.
Thank you for organising.
Thank you.
Thank you.
Thanks,
Bye.
everyone. Don't forget tomorrow night.
Don't forget tomorrow night,
Yes.
7 p.m. tomorrow.
We have our World Sickle Cell Day celebration.
World Sickle Cell Day tomorrow.
Yeah.
Yes. Yeah.
Thank you.
Join us tomorrow.
Bye. Good night.
Good night, everyone.
Thanks,
Thank
everyone.
you so much.
Thanks, Blood
Good night.
Donors.
Thank you. Good
Bye.
night.
Thank you, Blood
Good night.
Donors Australia.
Yeah,
Thank you so
thank
much.
you.